Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers. Today, the Substance Abuse and Mental Health Services Administration, or SAMHSA, the agency in HHS that's responsible for mental health and addiction. Dr. Yngvild Olsen, a national advisor with Manatt Health, served as the director of the Center for Substance Abuse Treatment at SAMHSA. She joins me to talk about SAMHSA's work in helping to address the country's overdose crisis, how things have changed since the Trump administration began, and what's ahead for this agency and its work. Let's listen. Dr. Yngvild Olsen, thank you so much for joining us on the show. Today, we're going to talk about SAMHSA and your work there and some of the changes that have been taking place. But to start us off, would you tell us what SAMHSA is?
SAMHSA is the agency within HHS, the Health and Human Services Administration in the federal government. And SAMHSA has been in existence for over 30 years. It was created by Congress to specifically focus on behavioral health, so mental health and substance use disorders. It provides grants, it provides technical assistance and training. It has a regulatory role in regulating opioid treatment programs and some of the confidentiality regulations related to substance use disorder treatment programs. So it does a lot, but it is relatively small compared to other HHS administrations like FDA, NIH, CDC. So a lot of people have never heard of SAMHSA, but it has a very unique role in our nation's behavioral health system.
And tell us, when did you start working there and what was it like to work there?
Yeah, so I started working there in September of 2021 during COVID. Everything was virtual, but it was really an amazing time. Because of COVID, there had been such an increase in overdose rates that had been increasing astronomically even prior to COVID, but COVID created this unbelievable increase in overdose deaths, in suicide, and just the stress of COVID, the isolation, had really had a tremendous impact on the behavioral health of the nation. And so we were very focused on whatever we could do to really reduce those numbers and make sure that we were saving as many lives as possible in conjunction with many of our federal partners, and just very focused in on that mission. And that made for some pretty exciting opportunities. We were able to incorporate much of what we had learned from that COVID experience. So working with our DEA partners to ensure that people could still get started on buprenorphine, a medication for opioid use disorder that has incredible evidence for saving lives, making sure that we could get people started on buprenorphine through telehealth platforms like audiovisual and audio only, like a phone call, essentially. That was exciting. We were also really able to incorporate what we had learned with respect to how people with opioid use disorder were able to access methadone in opioid treatment programs and really take many years of evidence and science and that experience that showed us that expanding access to medication to take home, for example, that was safe and effective, and it did not lead to what people had been concerned about, which had been increases in methadone-related overdose deaths. So all of that led to just a wholesale, really substantive revision of the federal regulations that govern and set standards for care in opioid treatment programs that we were able to finally publish in 2024. The last one I would just mention is, because we did a lot, but the third one that I think I'm really proud of is we very much focused on making sure that naloxone, which is the overdose reversal agent for people who are experiencing an opioid-related overdose, that was getting to communities and people that had the highest risk of either experiencing, witnessing, or responding to an overdose. So really making sure that naloxone saturation was something that was the norm across states and communities. And so we worked with 26 states, DC, Puerto Rico, to really have them focus in on making sure that naloxone was readily accessible and available.
And you mentioned that when you came in 2021, overdose rates were really at this high. What did you see happening to those numbers over the years?
What has been pretty dramatic is that if you look between, they peaked at around 110,000 or so in 2022, starting then in 2023, but really into 2024, we've seen a dramatic decline. So declines of like 25%, 30% in some states. That has not been universal across states or particularly across populations. So older African American men, for example, American Indian, Alaska Native communities still really have actually seen increases. So, but it has been a pretty dramatic turnaround. Why that has happened, people are continuing to look at this because that's a complicated question. Probably a big part of it has to do with the changes in the drug landscape. And so changes to fentanyl and the fentanyl composition of what people are using. But I have to say that I think with those and despite those reductions, that in 2024, we still saw over 75,000 people, almost 80,000 people lose their lives to an opioid overdose. So now really is not the time to be backing away from all of the things that we know from evidence have life-saving impacts.
So you were figuring a lot of things out at SAMHSA and starting to see some of that decline, but really still a lot of work to do there at the end of 2024. And then we have 2025, and there's a change in the administration. Can you talk us through, maybe what were you expecting might happen with this, and then what actually happened?
So, with the change in administration, there's always, as I was told by, my colleagues at SAMHSA who had been through multiple changes in administration, that there's always a little bit of uncertainty about kind of what the new priorities are going to be, what the new direction's going to be. I think, though, that there was a sense and a hope that because behavioral health, because overdoses and suicide, substance use disorders, mental health has been such a bipartisan issue for many years, that what we were focused on, the direction we were going in, that was going to stay, knowing that there were probably also some changes based on what we had been hearing from the new incoming administration and the potentially new incoming secretary. But we thought we probably are going to be working still very closely with all the incoming new folks. So we kind of kept our heads down, kept moving, kept planning, and planning to also now start to look at things like alcohol in a much more focused way, knowing that there were lots of other substance use and mental health issues that needed a lot of attention. So I think we were cautiously optimistic that we were going to be kind of continuing that way. What happened was that shortly into the new administration, when DOJ came in and started making huge changes to staffing, and we lost about 10% at the center of where I was the director. We lost about 10% of our employees just off the bat from the probationary employees that were let go. And then April 1st, when all of the reductions in force really hit across HHS, we were very shocked when people who were in positions that were in statute and congressionally mandated, that those people were let go. That was very surprising. And I think to us just signaled that SAMHSA was not going to be left untouched or unaffected by some of these major changes. I think the other piece that happened was later in the spring and the summer, when the fiscal year 2026 president's proposed budget came out, we saw that many of the discretionary grant programs across SAMHSA were zeroed out. These were congressionally created programs for the most part, and in a large category of grants called programs of regional and national significance. And while the administration's justification for zeroing these out was they don't have national reach, some of them are small directly to community-based organizations, they certainly have had local and even regional impacts. And so I think that to us was another signal that maybe we weren't actually as supported as we had thought in many ways. And so that really just caused a lot of ripple effects, throughout the agency and frankly, throughout the behavioral health specialty field across the country.
Along with, so these budgets were zeroed out earlier when there were the executive orders. Did you feel impacts on those grants from, things like diversity, equity, inclusion? Did you lose some grants through that as well?
Yeah, so those executive orders, they really changed the way that we had been thinking about and working on many of the grant programs and what we were asking of grantees to apply for. I think in large part because when you think about where the high risk populations are, particularly for substance use disorder, particularly for suicide and overdose, as I mentioned, older African American men, American Indian, Alaskan Native, LGBTQ, there are populations that we know are at much higher risk of overdose and suicide compared to the general population. Overdose and suicide can happen to anyone, but we were very focused in on making sure that the resources were getting to the people who are at the highest risk. Grantees needed to now to adhere to these executive orders. And in many cases, they needed to revise their continuation applications to continue to be able to get grant money. The thing that really, I think, hit us was when harm reduction also became a focus of the administration. We had for so long worked to ensure that people who were using drugs, who maybe were not engaged yet in treatment services, in other types of healthcare, that we were still able to meet them, and that the groups, the organizations, the communities that we were funding were still also able to provide services to them. Naloxone is a harm reduction activity. Providing fentanyl and xylazine test strips is a harm reduction activity. Really meeting people where they are and helping to support them getting engaged, and even providing buprenorphine, like I had mentioned, this medication that has incredible mortality benefits. That has often been a part of what harm reduction organizations provide on the ground. And so when the administration really started to equate harm reduction with something that they were not supportive of, that became a really, really significant issue for so many of the grants and so many of the grantees that we were funding.
So you have seen this whittling away of the grants, you've been losing staff, and then you see this zeroed out budget. What happened with that budget? And then take us into what happened in mid-January of this year.
Yeah. So when the budget came out, we were all kind of shaking our heads. Last summer, when the House and the Senate came out with their initial appropriations committee reports for FY26, they did not actually include many of those reductions. They, in fact, kind of left SAMHSA wholesale. The other big thing that had happened was that the administration had been proposing to reorganize HHS and would have subsumed SAMHSA, along with some other agencies, into something called the Administration for a Healthy America, which essentially would have changed SAMHSA's name. It would have kind of obliterated SAMHSA's name, most likely, and made it much less of a priority, in my view, and in the view of many in the field. So what happened in mid-January was that despite many of the changes that grantees had made to their continuation awards in response to many of those changes in policy and direction, SAMHSA sent out a mass grant cancellation notice on January 13th that essentially said, no, as of today, immediately, you are to stop doing whatever you're doing because we are canceling all these grant programs. If you look at that FY26 President's proposed budget, virtually all of the grant programs that received, or the grantees that received those cancellations, were part of those grants that were canceled out or zeroed out in that budget. But it went even a little bit broader than that. And there was such a huge outcry, both from Congress and stakeholders, grantees, states, just people in the field, that less than 48 hours later, SAMHSA sent out a notice saying, nope, never mind. We are not going to be canceling these grants, and you should continue on as you have been awarded these funds.
So you've seen evidence that SAMHSA is likely going to face many of the same scrutiny and cutbacks and changes that some of these other major administrations have had to face. But then something big happens, and there's all this outcry, even from Congress. It sounds like a big bipartisan effort to no, you can't do that. With all of this in mind, I mean, what do you think the future of this work is?
Well, I think a couple things. One is that outcry really, to me, demonstrated that, yeah, this is a bipartisan issue. This is not, overdoses, suicides, mental health, substance use disorders, it really cuts across and does not discriminate, right, against any one individual, population, community. And people recognize that. And they also recognize how important SAMHSA is and how important these funds are to making sure that people are getting the services they really need. What we have seen since January 13th is that both the House and the Senate, in their final FY26 appropriations bill, have left SAMHSA essentially funded, not moved forward with approving that reorganization of HHS and the creation of that Administration for a Healthy America. And they also reauthorized something called the Support Act, and President Trump signed it into law that actually reauthorizes and essentially approves the continuation of many of the grant programs that were slated to be canceled. So I think all of that to say that I'm hopeful that we really are now at a point where people will say SAMHSA as an agency is important. It has a role, an important role, a unique role, and that we need to really be supportive of it moving forward. I think some of the challenge now is that we have all the grants, we have the FY26 appropriations that maintains all the funding, and yet the agency has lost about a third of the staff that they need in order to really be able to manage all of that funding. What that is going to mean, and what that has meant, is that many of the grantees and the attention that they were given before from their grant project officers, from many of the support activities that they need in order to be able to do their work within SAMHSA, that has gone, and things may be slower. Grantees may not be getting the kind of timely response that they really should expect. And the oversight of grantees is something that I think may be challenged. And I worry about the morale within SAMHSA, but the people who are there are so incredibly dedicated to the mission, to the work. They're going to do their utmost best to really do as much as they possibly can with fewer people. So many other things that now are in the news that people are having to deal with across the board, lots of uncertainty. So it's not to say that there can't be and won't be continued changes to SAMHSA and some of these grants and other pieces that SAMHSA is involved in, but I am hopeful that really we're going to be able to continue moving forward as a field and as a country to continue to really see the reductions in overdoses and suicides and just the support that people need in order to be able to address their substance use disorders and mental health conditions to the benefit of not only themselves, but their families and communities and society at large.
Well, Dr. Yngvild Olsen, thank you so much for joining us to talk about this today.
Great. Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.